Thank you, Heidi and Select UK for inviting me. I hope you will forgive my Italian English, but after David Price and David Sanders, I had to ask some support to attract your attention. However, to biopsy or not to biopsy, I think the bard is rolling in his grave. He doesn't know really, and so we have to go on. So the expert here to ask and to provide some answer is certainly our professor David Sanders. So you heard about the importance of biopsy at follow-up. In my opinion, and I will try to convince you, it's much more important at biopsy in the follow-up than not at diagnosis in the vast majority of cases. So this is what the pediatrician has done. Most of you are familiar with the ESPGHAN criteria, the European Society for the Study of Pediatric Gastroenterology and Hepatology. And you see here that in symptomatic patients, when the anti-transglutaminases antibodies are very, very much positive, times 10 to the normal range, then in a second blood test still positive, then you can go to the gluten-free diet not having the biopsy, which is understandable because it's a procedure, invasive procedure, and it requires anesthesia in children. And still, in adults, we think that adults should always undergo biopsy. My question is that always necessary? Is that possible that a subgroup of adults with celiac disease, with positive serology, not the one that David Sanders mentioned, IgA deficient, low titer, with positive serology, may not need a biopsy? And there are some papers and studies already published. They are mostly retrospective studies. Why we should do the biopsy? Why so many years are now that we do biopsy, and it's convincing that we have to do biopsy? Because it's a safe procedure in adults. We may miss another diagnosis. We need sometimes to make a differential diagnosis besides celiac disease. And we like to have precision in diagnosis. It's like, no, you complete the picture. You have the serology, then you have the mucosal damage, which is fine. And also because we know that some patients are called potential. They have the serology, positive serology, but the mucosa is perfectly normal or has a slight infiltration of lymphocytes. And in this case, if not doing and relying only on serology, those patients would go immediately on a gluten-free diet, and we don't know that they have an healthy mucosa. But the truth is that most of potential, and everybody who does this knows, they are picked up in relatives of celiac disease, or they generally, when they know they have the positive serology, they start spontaneously the gluten-free diet because they feel safe. And so probably it's not a big issue, but we will see about. We may miss the complication. You have heard the beautiful talk of David Sanders about refractory celiac disease. But as you heard, refractory celiac disease cannot be diagnosed at diagnosis, at the first moment we do the first biopsy. It takes some time to recover, and then when the patient is not recovering, then you start thinking about refractory. So it's a second moment. And this is true also for the other complication like cancer, lymphoma. So the biopsy strategy in adult celiac disease, this is, I couldn't find the paper. Not published yet. So, but this one was presented at the European Gastro Week. So they tried to apply the ESPGHAN criteria. It's a multi-center UK study, right? And they enrolled this more than 400 patients, and they found out that when the GI symptoms were present, about 70% had high titer of anti-transglutaminase IgA antibodies, positive serology. And then when that serology was coupled to the anti-endometrial second blood test, they were predicting villus atrophy in almost 100% of cases. I want to tell you there is no other test so powerful in predicting a disease. Not even glucose can be so powerful in predicting diabetes, because you need to do it in certain circumstances. So the time X level of the anti-transglutaminase IgA pathology has a predictive value of 100%. It's even a little bit scary. In medicine, 100% sounds always complicated because, you know, the reality is different. So how about complications? As I said, complications are quite rare. If we look at the great number of patients, this is a national study, Italian studies that we have done. And so we look at more than 2,000 adult celiac patients. 16 of them developed the complication and 29 died as expected, no more than expected. And the complications were all above 60 years, and the risk was increasing 18 times when this group was compared to the median age, the younger age group, 18 to 40 years. The classical presentation increases the risk. Remember the scar lion, the lion with the scary face, increases the risk of complications 7 times. But also, we found out that patients with low or no symptoms, the risk of complication was virtually absent, which is very important when dealing with patients, because we have to predict what to do and to deal when we deal with them. So what are the main issues? Contra biopsy. Serology has this high predictive value, and once that you have such a predictive value to have villus atrophy, who wants to have an endoscopy? Patients don't want. Most of them in Italy now, they go to gluten-free diet with positive serology. They don't want. And they are even willing not to have the social system support for gluten-free food, which is for free in Italy. In the vast majority of cases, when you do the biopsy, the histology will confirm the diagnosis made out of serology. And sometimes, or very often some places, the biopsy are few, less than needed, non-oriented, and the pathologist will not appropriately describe the mucosa. And I'll show you what I mean. This is the piece of mucosa that we are just pinching here in the second duodenum with the forceps. See? We have to place it villi up on a piece of absorbing paper, and this goes into formalin, and this goes like this to the pathologist. It is very important that the pathologist will cut the pieces longitudinally, this way. Because if the cut is done that way, tangentially, then all the villus tip will be cut, and it will look like this one. This is a computerized 3D model. So the crypts will look like round, and the mucosa will look like atrophic or partially atrophic. But that is a mistake. So in Italy, we know that about 30% of our biopsy are like that, because we don't have the time. It takes time. It takes time to do this in the endoscopy. It takes time to cut it properly at the pathologist. It takes probably 15 minutes per bio. So it's a lot of time. So what in this paper, this one was judged as a normal mucosa, you see, because this is villi. But when it was properly oriented, tilted, and cut again, then it looked like an atrophic mucosa with villus atrophy, so a clear sign of celiac disease in this case. And when the authors show this mucosa, which is a real biopsy, as taken from the pathologist, to 5 independent pathologists, they were judging it regular mucosa, but then reoriented. They found that there was a lesion, MASH3BC lesion, that means atrophic mucosa with cryptohyperplasia. So it's very, very much important to do this. So Vincenzo Villanacci, who's now part of our study group, is a pathologist, is showing us all those disaster, he calls them. So that, clumsy pictures. And there is another problem. If you take the biopsy very early in the bulb, in the duodenal bulb, not in the second jejunum, then you will get into the Brunner gland. They make a distortion of the architecture. And so you need to reorientate the piece so that the glands are down here, and so the villi will show nice and slim, and you will see there is no atrophic mucosa, and this is a normal mucosa. So biopsy or not biopsy, we need an expert opinion and few studies to decide what to do. And going to expert, Professor Holmes, who is here, is a clear expert here in UK and in the world. So I was honored to write this commentary, I would say, short paper, I don't know, opinion paper, about a new strategy for a selection of patients, of adult patients. We think that a young patient, let's say a 30 years old lady with high titer antitransglutaminase antibody, no other sign. Why should we think about complication? Why do not treat her as a 16 years old lady going into the ESPGHAN criteria for pediatricians? So actually in the same journal, there was a word of caution by the people from Professor Sanders, and they say, well, but we require multi-center prospective study to decide what to do with this kind of patient, to identify the patients that are safe without a biopsy. In the meanwhile, overseas, the American Gastroenterological Association, they do not change the guideline, but they wrote this clinical practice update in which they mention that strongly positive antitransglutaminase antibodies plus endomysial antibodies in a second blood sample have a very strong positive predictive value for villus atrophy, and that in adults the endoscopy and the biopsy might then be performed for purposes of different diagnoses, not for diagnosing celiac disease. Now, this is the study. This is the first time that I present preliminary results. This is a multi-center, prospective international study to evaluate the possibility to avoid duodenal biopsy in a subgroup of patients with celiac disease. In this case, we are looking to positive and negative serology altogether, just to understand well how to identify our patients. We are collecting the data of the patients, the blood sample, and the histology, because we will send the sera to central labs and the histology to a central pathologist, and then we are following the patients. So far, 19 centers are participating. Italy is 6, but you see here Tampere, New Delhi, Iran, Romania, those people here, they are waiting for ethical committee approbation, and Spain, 3 centers in Spain, and also New Zealand, Kamran Rostami, that you might know, is joining us. It's just joined us. In the past months, we collected 220 patients. You see that mainly they were making the serology, and the suspicion of celiac disease was done because of iron deficiency and GI symptoms, but also we found at least 4% of them with no symptoms at all. And serology, and then we found out how different is the way we deal with patients, because in some centers they use only the anti-endomysial antibody. If they are positive, that's it. And in some others, only the anti-transglutaminase antibodies. And in some others, the double test, the anti-transglutaminase antibody and a second blood test with the anti-endomysial, sometimes together. And it's the vast majority. And then we found that the vast majority of patients, you see here the numbers, have a clear damage at the mucosa, intestinal mucosa, but some others they don't have. Those patients will be re-evaluated by the pathologist. We will send him all the slides, and he will check with other two guys exactly the orientation of the mucosa mainly. And at final, our patients, we found a positive diagnosis for celiac disease in 130T and other diseases that you see here in the other case. So just my take-home message, there is the possibility that a subgroup of patients, especially the young ones, especially with the very low symptoms, they could avoid biopsy. And the ongoing trial will probably give us a center. And this is a place where I work in Salerno, but you may be familiar with Amalfi Coast and Sorrento, so it's very close. So if you come down maybe for a vacation and you want to visit us, I will be glad to have you there. And this is my motto. The difficulty lies not so much in developing new ideas, but in escaping from old ones. So thank you very much for your attention. Okay, I'll take your questions, but you please speak slowly and maybe repeat.
Thank you very much. I'm Peter Gillett. I'm a children's gastroenterologist from Edinburgh. Thank you very much for your presentation. 6 years down the line from the paediatric guidelines, it's great to see that there's a prospective study in adults. How many patients do you aim to recruit?
Good question. 700.
700.
Yeah.
So very similar to the PROCEED study from Werkstetter. It was very interesting to hear that you're really finding the same issues. The most the unsolved issue in the paediatric study is how rubbish the histology often is, and the reports from pathologists, orientation of biopsy. So it isn't really a different scenario at all, is it? Similar treatment, no need for biopsy, I think, in a select group of patients, I think, is to be welcomed on the adult side too.
Well, I hope you're right. I think I totally agree with you. Yeah. But, the pathology is a problem. In some centers, not tertiary centers, let's say it's a real problem. Sorry, the lights are... Oh, no.
Yes, thanks, Carolina. That was wonderful. I think your motto is wonderful. Not so much learning new things as forgetting old ones. And it's incredibly difficult for gastroenterologists to get out of this mindset that a biopsy is essential in all cases. And we're still talking about, well, we need more studies and we need more this and we need more that. I think the evidence is already there, that if you have patients with a high titer of TTG and you show it to be consistent with villus atrophy, then problem solved. But people still persist in talking about positive serology. I've forgotten about Jeremy Woodward's paper that David referred to. I shall have to have another look at that. But it's no good talking about positive serology. You've got to talk about titers. And each laboratory and each centre has to decide what test it is using, because some tests are useless, what titers they're going to act as villus atrophy. And under those circumstances, I think that there is a group of patients who can very, very confidently be diagnosed without biopsy. And I don't think it's going to compromise people with refractory celiac disease in any way, because if you've got refractory 1, you're probably not sticking to your diet. If you're refractory 2, you need a whole lot of tests other than biopsy because they're really sick. So I think we are moving ahead, and I think as gastroenterologists we are very lucky to have these tests, as you have said, because they outperform just about every other medical test that we have. But we still have to use them intelligently, and I think that we are moving away from a morphological diagnosis of celiac disease to a serological one, and I think that is safe and acceptable, and I think patients will like it. Thank you for
so
your
much.
wonderful paper.
Thank you. I totally agree with you, but everybody knows that. So.
Any further questions?
Okay.
Oh,
thank you.
there's one
Yeah.
more.
Thanks. That was really interesting. I think my question would be then, what situation does that leave the follow-ups for these patients? I guess that opens maybe a bit of a bigger question. If they sort of at diagnosis know they don't need a biopsy, then further on, does it make that assessment of, say, compliance, how well they're doing, does it make it a lot harder with these serological tests?
Yeah. Well, in this study, we just imagined a 6 months follow-up, but we probably could, also imagine a longer one, because it takes time to understand if you're responding. And all those patients, they do have the biopsy now. So this is classical way to make the celiac disease diagnosis so far. So one thing that Professor Holm said that I think is very important, some TTG tests are just rubbish. So this is why we will send our lab test, the blood sample, to Tampere, Finland, University of Tampere, and to Innova Lab in San Diego, California, which is the top in this moment quality of assay. So we will check also the local problems, the tests that all the centers are using. And that would help a lot in predicting the future, how to follow them up. But I have to say that I like to do the antibodies, the serology also in the follow-up. Because yes, they are unuseful if they are negative and the patient has the symptoms. But if they are positive, if the antitransglutaminase is positive, then and the patient has symptoms, then you need probably a reassessment with the nutritional. I mean, there's going gross mistakes or voluntary mistakes, so they are not really unuseful.
That's a lunchtime discussion. I think.
Yeah. Okay, thank you.
Carolina, thank you so much.